All right, so let's just get started, everyone. Hi, everyone. Happy New Year's, and welcome to our first educational event of the year, our first Wellness Wednesday on New Year's goals and resolutions. My name is Lily, and I'm one of the program assistants for the BC Brain Wellness Program, and I will be your MC for today. And before we dive in, I do want to take a moment to acknowledge that the BC Brain Wellness Program at the Javad Moafan Center for Brain Health resides on the traditional, ancestral, and unceded territories of the Musqueam peoples. As a settler here, I think it's really crucial to recognize the profound relationships we have with the Indigenous peoples and the land, and to continue to honor and nurture these connections. It's truly a privilege to be able to offer our program on Musqueam land, and I know we're probably joined from various locations today, so I urge each of us to check out the resource to understand the land that you may be inhabiting. So it will be in the chat. So let's move on onto introducing our lovely speaker today, Dr. Lesley Lutes, who we are so grateful to have join us. So a little bit about Dr. Lutes. She's a full professor, director of clinical training, co-director of advocacy for the BC Psychological Association, and the director of the Center of Obesity and Wellbeing Research Excellence at UBC Okanagan. Dr. Lutes is a registered psychologist whose area of research is in developing innovative behavioral treatment interventions focused on lifestyle behavioral changes, mental health and well-being, as well as research and policy change related to increasing access to evidence-based psychological services through the primary care system. She has published over 75 peer-reviewed publications and has secured over $7 million in research to date. And she has also been featured in many popular media outlets such as the Globe and Mail, CBC, and Global News. And she also recently won the Researcher of the Year at UBCO in the area of health. So for today's event, Dr. Lutes will be talking about how small relative behavioral changes lead to more sustainable lifestyle changes in the context of New Year's resolutions and goals. And to end off, there will be a reflective engagement and discussion activity led by our great PAC team in breakout rooms. And this activity will encourage participants to think about their own goals and resolutions as we kickstart the new year. And I also want to take a moment to thank all of our program donors for supporting the BC Brain Wellness Program. It is because of your generosity that we are able to offer these accessible events and classes. So as an entirely donor-funded program, we rely on your generosity to ensure the continuation and development of our program. So thank you, thank you, thank you for your ongoing support. And just a couple of housekeeping notes before we begin. If you have any questions for Dr. Lutes today, please type them in the chat box. If you want to ask your questions privately, feel free to send a DM to me directly. And there will be a Q&A session at the end. Reminder to keep your mics muted throughout the talk, and we will end this Q&A session at 1 and transition into our activity. So please stay on if you can. And this presentation is being recorded, and a link to the recording will be sent to those who have registered. All right, and just a couple of other announcements. We are actively recruiting for 2 research studies. So the first one is our Impact 360 study. So we are recruiting for healthy agers and those with Parkinson's to understand the health impacts of a combined virtual exercise, cooking, and mindfulness class intervention. So if you're interested, our email is there. Oh, Lisa, sorry. Next. Yeah, and then we also have another study. This is a new one. This is a dietary intervention study to understand the impact of diet on symptoms and the microbiome of those with Parkinson's. So if you are interested in this study, feel free to contact annie.kwan@ubc.ca. And if you know of anyone who may be interested in one of these 2 studies, it would be greatly appreciated if you can pass on the message. And these interventions are of no cost to you. And lastly, on January 27th, we will be hosting an in-person sunshine workshop. So we encourage you to join us as we empower each other through the power of our voices. And that is all from me. And without further ado, I will pass the mic to Dr. Lutz. Welcome.
Thank you so much, Lily, and thank you everybody for having me today. Happy New Year. I'm so grateful when Lily asked me to do this talk, and I'm thrilled to be with you today. So I'll go ahead and share my screen and see if everybody can tell me if you can see it okay. We'll go to the presenter view. Can everybody see my slides? Okay, perfect. Well, thank you for that very gracious introduction. So you guys know a little bit about me technically and the roles that I serve at the university. And I'm joining you here today from the beautiful Okanagan Silks Nation in Kelowna. That's where I live and reside. But my real heart is with my boys. I have two young boys, Eli and Max, 7 and 12, actually, who just turned 12 on New Year's Eve. So New Year's is a special topic in my heart. So that's kind of how I ground myself in, and what I'm going to be sharing with you today is thinking about what do we value, what's most important to us as it relates to how we go forward in terms of our new year and intentions and goals. So I think that everybody now hears it every single year, New Year's resolutions, New Year's resolutions. It's a time tradition for people to set New Year's resolutions. But what the research shows us that over 90% of patients, individuals, us mere mortals, myself including, do not keep those New Year's resolutions. And the question, right, is why? And I can tell you today, I'll share with you, it's not because you lack the willpower. It's not because you just don't care about those things. There is a science, very clearly a behavioral medicine behind it, that impacts people's intentions to the behavior. I call it the intention behavior gap. But there's also other things like chronic health conditions and mental health that significantly get in the way, that impact our ability to make changes. So I'm hoping today in the next 40 minutes, I can really help you understand and start to think differently about how we move forward and how we go about setting intentions or plans in a more kind of based on the research, but also a more holistic way that encompasses all facets that impact your health and well-being. So, oh, I'm having a little hard time here with my slides aren't advancing. Let's try it this way. Okay, so on actually, speaking of news, I do them regularly. And on New Year's Eve, I did do an interview with Gloria Macareno, and you guys will have access to the slides so that you can listen to the clip if you want, but you're going to get an expanded version and very detailed. But we spoke about this just on New Year's Eve. So when people talk about New Year's resolutions, they kind of talk about it as a simple way, like try this exercise, go to this gym, try this diet, cut out this sugar, eat clean for the month, drink, go dry for January. But I want to step back and have us understand it is not that simple. And there is no one thing. There is many, many things that contribute to our ability to make changes and health changes. And so I put that in the context of understanding exactly where is the current state of physical and mental health of Canadians? And I think that's an important thing to understand. So we know obesity, weight-related chronic conditions has literally doubled in 73 countries, and that we know that increased weight is related to important linkages between cancer and years of life lost. And the pandemic was particularly hard hit for those living with chronic health conditions, including excess weight. In terms of obesity, was tripling the rate of hospitalization. And COVID disproportionately impacted racial ethnic minorities, women, and people living with disabilities or mental illness, and those populations being less likely to have access to preventative-based care. In Canada, it's no different. If you are not struggling with weight as a part of your daily life, you are in the minority. 6 in 10 Canadians now are living with either overweight or obesity. We're spending over $7 billion from government for direct costs of billing. And actually, diabetes and diabetes-related conditions are the fastest growing financial costs to the Canadian system. And we know that education and age increase those risks for people. And I've broken it down by province. Essentially, also, is perhaps the number one issue facing related to other chronic physical and psychological complications, morbidity, mortality that people often don't talk about, understand, or our government absolutely do not understand that connection between the mind and the body and how it relates to health and health behavior change. So we now know that weight status is linked to 12 different types of cancer. It's the #1 killer in Canada. Cancer and heart disease accounts for 50% of the deaths in Canada. Heart disease is the #2 killer in Canada. And 6 of these 10 leading causes of death in Canada are related to non-communicable diseases. Now, I want to be, again, clear. People have talked about tobacco use and alcohol and physical activity and nutrition, and that's where they think goal setting and New Year's resolutions are an easy way to fix it. But again, I will hopefully compel you today to understand why there's a lot of things working against us, but things that we can actually do to start change the tide in terms of behavior change. The other component that people often don't talk about is the role of mental health, anxiety, depression, trauma history. Death by suicide is actually the 9th leading cause in Canada. And a lot of people have talked about the youth and young people with the risk of mental health and suicide, but it's actually middle-aged individuals, particularly those living with chronic health conditions, such as chronic pain or others, are the #1 group at risk that is not being treated. So again, we'll treat the physical health condition, but not the mental health condition that actually is impacting their ability to make physical health changes. Now, when we talk about diets, the #1 New Year's resolution for people is, I want to lose weight. I want to, go on a diet. I want to lose 10 pounds. I want to be healthier. But the actual research, and this was summarized nicely by the New York Times a couple of years ago. I can show you all the science, but essentially all the reviews showed that the mounting evidence is showing that just traditional dieting doesn't work. Research shows that food restrictions and giving ourselves, if I love chocolate cake and I say I'm not going to have any more chocolate cake in 2025, it actually just makes us want to eat more, right? In the long run, dieting can backfire, can trigger your body's survival defenses, slowing metabolism, and making it even harder to lose weight across the future. Now, what are some problems when people do try to set goals? And again, I'll talk about how I think we could be setting goals based on science and evidence that can be more supportive. But traditional goal setting of, I'm going to go to the gym 5 days a week, if you've not been to the gym in 20 years, is that we're not taking into consideration other things in people's lives that are impacting their ability to enact these intentions or hopes and plans that they have. And that is time, stress and emotions, family and social support, knowledge, competing activities, feelings of failure, and feelings of deprivation specifically related to food restriction. And I have been arguing now for 2 decades. My work first started in my doctoral dissertation, of which I won Dissertation of the Year by the Society of Behavioral Medicine in the US for the most brazen attempt of trying to stop having people diet. And this was 20 years ago, and we just started the dieting trend, and it's now more big business than ever. But I've been arguing that just traditional dieting recommendations to people, and I'll show you in just a minute how the Canadian Medical Association now agrees. But 20 years ago, I was saying that we are setting unrealistic patient goals for our patients, unrealistic rules. We're asking to focus on temporary behaviors, change that's too costly, change that's too difficult, treating weight or health chronic behavior issues as an acute problem, and not addressing contributing and maintaining factors such as emotional or binge eating, depression and trauma, and other factors such as distress related to managing diabetes, which are big predictors of behavior change. So over the last few decades, some of the biggest individuals in the field, which I was very honored by coming online and supporting the work that I've been trying to put forward to the research field and now to the BC and Canadian government, is that a field leader such as Dr. James Prochaska, professor of psychology at University of Rhode Island, said our culture gives people 2 options, either take big action or do nothing. And then when big action fails, people come back, get demoralized, and go back to doing nothing. This is this all or none cycle that essentially I think that the dieting and exercise industry have been contributing to in terms of us feeling, if we can't stick with it, that there's something wrong. And Dr. Darush Mazzaferin, the dean at Tufts University, and arguably one of the leading researchers in the world talking about nutrition as predictors for morbidity and mortality, saying that the rare individual can make dramatic lifestyle changes and stick to that quickly. That most of us mere mortals like myself cannot adhere, and the data and the research shows only 10% of people can adhere to these very strict regimens of food. And in light of that, over the 4 years ago, or now 5 years ago, the Canadian Medical Association published a very seminal piece in changing recommendations for patients struggling with weight in Canada. They now said that obesity should be treated on evidence-based principles of chronic disease management, validate patients' lived experience, and move beyond simple approaches of eat less and move more. And that addressing the root drivers of obesity and understanding biological and other factors that contribute to people's ability to make behavior changes. So I was quite heartened, and as someone who is from British Columbia, then moved to the US for 20 years to do my graduate training in behavioral medicine and clinical health psychology. When I came back to Canada in 2015, was quite dismayed to see the lack of understanding between the mind and the body, and the lack of funding for helping people manage lifestyles, which are a significant predictor of challenges for individuals and in our society. So I was thrilled when the Canadian Medical Association came up with this recommendation in 2020. So for the last 20 years, I have been advocating vehemently that people do not need another diet. What they need is our collective research community and our governments to change our approach towards effective treatment, so that not only is it evidence-based, but that it's realistic, that it's sustainable, it's generalizable, and it encompasses the whole person, so that it can help them improve their health and well-being. So, does it make any difference? Does it make any difference? Well, let me tell you what in 2004, I formally developed the small changes approach, which has been featured in many pre-revered journals. But my joke that my mother, who passed away this past year, she said she used to keep all my magazine outlets of things like in Real Simple that I was in. She thought those were the real testament of information that was becoming real information, not just in a scientific goal research. So the small changes approach is really that participants set small goals, not big ones, that they're meant to be one at a time, and that more is not better, in opposition to what everybody hears, and that it's relative to baseline. There's no gold standards. If you're not doing any activity today, goal setting for 5 minutes of activity 3 days a week moving forward is a huge, significant change. That's very different than saying I'm going to exercise 5 days a week and go to a gym for 30 minutes a day. And it's really focused on behaviors. And this is the very simplistic. I'll get into the more complex things and breaking it down in just a minute, but focusing on behaviors and not on the outcome. A lot of times the number one goal is I'm going to lose 5 or 10 pounds. Well, that's like saying I want to go to Paris, but not knowing how to buy the ticket, how to go, right? How to get the organization to know how you're going to take the trains to get there, get over there, get in the city, book your hotel. So we stop focusing on the outcomes, but start focusing on the actual behaviors that will get you moving towards more about what you value and what's important to you. So the main premise of small changes, which was very opposition into traditional dieting, is that small changes is not a diet. It's not a temporary way of life, and it's not a program that has forbidden foods. Small changes is more of a lifestyle, and I don't like the term restriction, but mild caloric changes, which I'll show you more about in just a second, eating everything in moderation, and dealing with each thing as a choice. And again, not this all or none. And in theory, right, the small changes, and again, I'll give you more detail in just a second, but the small changes approach is meant to be self-selected. So not by what other people think. It's meant to be very concrete and measurable and action-oriented, the who, what, when, where, the details, that we know the science of what's called implementation science helps us when we're doing a who, what, when, where goal. It allows us moving from our intentions to actually implementing the goals. And also that is linked to your life. One of the common goals I often get asked on interviews is, well, do you set a goal? And I said, well, I can tell you one goal I don't set. So oftentimes I've heard, if you just the 5 a.m. club, I don't know if anybody's heard about this new, just wake up at 5 a.m. and do these things, and you'll be so effective. I can tell you, as a working mother of 2 young boys, my sleep is precious. I set my alarm for exactly 10 minutes before they wake up, and then we're getting ready for school and doing things. Then I'm heading off to work. I'm not going to be able to, in my life, get up and work out at 5 a.m. or 6 a.m. So setting a goal like that wouldn't be linked to my life and wouldn't be reasonable, be setting me up for failure. And then it has to be limited in time. A lot of times people think that goals need to be, I'm going to do this forever. But what we know is that we have to figure out what works, but what doesn't work. And I like what I call trying changes on for size. Try working out or try doing something, eating something for breakfast one morning for a week. If it doesn't work, evaluate why and figuring out what doesn't work, or people would call traditionally failure. I say it's figuring it out. So trying something on for a size just for a week or so to see if it makes a difference and tweak as you go. And then participants setting goals that are small, not big, one at a time, more isn't better. And again, relative to baseline. So that's really been the standard. And this program has iterated. I'll show you some of the research that over the last 20 years, it's been tested in over 20 clinical trials with multiple different populations, including veterans, people with depression, diabetes, obesity, with psoriatic arthritis, with atrial fibrillation, and multiple different ethnic and cultural groups as well. And essentially, some of the topics that we cover are talking about the baseline assessment. People are so quick to go and make changes right away. But what we say is we have to understand what you're currently doing and setting goals relative to what you're doing now. That is where half the people fail right out of the gate in terms of making some changes, because they don't take into consideration what they're currently doing. And then identify behaviors that are negotiable and don't touch the ones that are not. I'll give you an example of that in just a few minutes. And then this dieting mentality. We spend often several weeks in the programs just talking about getting rid of this dieting mentality. Feel like in order you have to restrict or deprive yourself of things in order to be successful, that actually that sets you up for failure in of itself. And we spend several weeks getting rid of that dieting mentality. And then this was the most controversial thing of the program that is now still in place, but it was controversial 20 years ago. I actually started a mindful eating practice, not of raisins and not of carrots. I don't know about you, but I've never overeaten or binged on carrots or raisins in my life. I've binged and overeaten on Sour Patch Kids, on chips, on ice cream. And so we actually bring in the foods that they typically would overeat or binge on, and we actually do a mindful eating exercise with those things. And then we talk a lot about emotional eating. For those people, we know that 1/3 of individuals struggle with binge eating or emotional eating as a component of trying to make lifestyle changes. And so we tackle that head on. And then also talking about problem solving and social support. But problem solving is a skill that has to be taught in terms of the research that's showing it's a skill set, like learning to ride a bike, that we help enact and support people in. So I'm going to give you some examples. And at the end of the talk, I can tell you, I'm going to be giving you free access to my well-being, my enhanced program that has been just for participants in studies before, but I'm going to give you access to all the materials. I've now made them public. So you'll have access to all 12 podcasts as well as material downloads to be able to look at all of these things in much more detail. But I want to give you just a few snapshots about some things that I think are most important that I want you to consider as you're thinking about goal setting and moving forward this year. The first thing is thinking about any goal setting or changes that you're wanting to make, is that it's in line with what your core values and what's important to you. So the first example I often like to give is myself. So my core values of what the three most things that are important to me are my family, are my health, and are my community. So am I doing things that are moving towards those goals and behaviors and things, and how I'm spending my time? Is that moving me towards what I value? Or am I doing things that are taking me away? So one of these exercises is to identify for you, what are your biggest things that you value in your life? Is it family? Is it health? Is it intimate relationships? Is it parenting? Is it achievement? None of these things are bad. It's identifying what things are important to you so that you're doing things that are moving you, helping you move towards those things. So now I'm going to break down into the small goal acronym. So I'm sure everybody's heard about SMART goals, but 20 years ago, I've started small goals, and it's now permeated. I actually think My Small Changes program has actually been implemented in 60 primary care clinics in Burnaby, and I'm looking at trying to do provincial-wide implementation of actually having personal coaches as well as access to the program. But I want to share with you the small goal acronym, because I think SMART connotates if you're not doing it, then you're not smart. And so 20 years ago, before SMART goals were developed, I developed small goals. And I hope that you reflect on this, and maybe this is something you consider in that breakout room, is how do you set a small goal? So the first thing would be, is a small goal has to be self-selected, can't be your own. You have to choose a goal that fits into your life and that only behaviors that you're willing to negotiate at the present time. So even though, let's say I'm really busy, being a good friend is value to me, so I'm willing to make more time to connect with my friends. That's an example of something that's important to you and something that you value. Then you get into the M. It has to be measurable. So how am I going to know that I met that goal? So let's say for me, a measurable goal with an ankle injury, for me, I haven't been able to exercise or run in almost a year and a half. I now said I'm going to try and go to Pilates once a week for me, for my ankle, for my rehabilitation, and that's the metric. I know it's measurable. If I go, then I've met my goal, but it's got to be a measurable, concrete thing that you can see whether you've met that goal or not. And then action oriented. So how are you going to achieve that goal? So a lot of times I see patients 1 day a week in the student health clinic here on campus. And a lot of times they'll say, I want to eat healthier, but I just don't have time. And then I forget about it. And then I get overwhelmed. And I don't do anything. So our plan is we break it down into action oriented. I say, okay, when are you going to go to the store? Well, I can go tonight. What time? 5 o'clock. How are you going to get there? And what are you going to get on the list? And then what are you going to cook tonight to get started for that? So we break it down into very action-oriented who, what, when, where. And we hope the why is going back to that what you value and what's most important to you. And then again, the one I talked about before is linked to your life. Goals that are best achieved, the science shows us, is that if they work within your lifestyle and they match your challenges and your strengths. So if you're not an early riser, I do not suggest you set a goal to be a part of that 5 a.m. club. If you are, then maybe absolutely that'd be great, but it has to be linked to your life. And then the other one is time limited. I do not like this permanent idea of like, I'm going to do it forever or that's it, I'm going to give up. Try it on for size, try it for a week, see how it feels. And whether it's working or not, you're figuring it out. You're not failing. And I call it, you're figuring this out to figure out what works for you. Another session content that we have is taking care of yourself in terms of physical well-being. So fuel, movement, fuel is another word for food or nutrition, and movement and rest. These are 3 huge components that impact our mental health and our physical health and our management of chronic health conditions. So this is where the other thing I'm going to introduce before I have 2 other introductions to talk about. SMALL was the first acronym. My other thing that patients have repeatedly in all the trials, I think I've treated over 2,000 patients now in all of these different trials in both the US and in Canada and in BC. The QQF is by far, they call it their fan favorite. So let me talk about the QQF and what it means. Oftentimes people say, I'm going to eat this or I'm going to not eat this. It's like all or none thinking. And to say, I had one patient once that said, Lesley, those 2 Otis Spunkmeyer cookies are the only thing that keeps me going at the end of the day when I'm dealing with all of my stressors. So don't take away my Otis Spunkmeyer cookies. And I said, that's totally fine. So what I hear is right now, the quality or the quantity of those foods, of those Otis Spunkmeyer cookies, you're not willing to negotiate. And she said, right. And I said, but would you be willing to negotiate how frequently you eat them? Maybe it's 6 days a week instead of 7. She was like, well, I never thought about it that way. So it's starting to introduce these shades of gray. It's not all or nothing. You want to think about the quality of the foods that you're eating, the quantity, and the frequency. So I'll give you an example. So again, the quality is like talking about replacement of white versus whole wheat bread. That's a quality change. A quantity is how much of it you're eating. I'll give you an example in the next slide. And then the frequency, how often you're eating those foods. So it's not just all or nothing. I'm either making these changes or not, but you're thinking about each of these nutrition changes or in terms of quality, quantity, and frequency. Here's just a very basic example of in theory. I commonly had patients in our studies in North Carolina who loved Coke. And that was the conversation of, I love Coca-Cola, don't take away my Coke. I hate Diet Coke and I hate water. And actually, the research shows us that taste finders, we have certain taste receptors that some people actually don't like, that they have an aversion to the Diet Coke taste. Some people don't. Other people have aversion to the water for the feeling of it. Other people don't. So if for you're a person that loves Coke, they said, well, the goal was maybe I can go down to one. I'm willing to make a quantity change, not a quality change, not a frequency change. I'm willing to go down to one Coke a day, but I still get my Coke. So if you look at just the technical math, now assuming, remember, we don't do same behaviors every single day of the whole year, but I'm just going to give you an example of how one small change in quantity, right, can make a change across time. That would save you 155 calories per day if that's just what you changed out for a Diet Coke or water. 1,000 calories saved over the week, 56,000 calories saved over the year, and 3,500 calories or per pound. In theory, if this is something, an activity that you did every day and you changed it, the data actually shows, and my small changes studies have shown, that people can lose a clinically significant amount of weight, of at least 5%, if they're making a change that's sustained across time. So it doesn't have to be changing your whole diet, but considering one thing that maybe you could look at quality, quantity, or frequency to potentially change. Now, I'm not going to bore you. Yeah, sorry. I'm not going to bore you with all of my research, but here's examples. I've published my studies in top leading journals, including the Canadian Journal of Diabetes, in the US, the top leading journal in diabetes care, in patients. We did the largest trial with veterans in the US for weight management. I've published several of those articles in Obesity, American Journal of Preventive Medicine, and many other contemporary clinical trials, you name it. So in patients with chronic pain and all of these different other groups and populations. The resounding results are showing that patients feel less restricted, they feel more empowered, they don't feel it's all or none, and it's starting to take into consideration other factors. Now, we're not talking about things such as clinical depression and other chronic health conditions, which I can talk about in just a minute, that also play a role. But in general, it seems to be a less significant impact on people's lives, that they feel like it's more maintainable and they can tweak as they go. And one of the biggest nods, I think, was the study I did with the Mayo Clinic several years ago, which we had patients that were not eligible for gastric bypass surgery, and they had to use liquid meal replacement for losing weight. They would lose 20% of the total body weight, and then within 1 year, they gained all of that weight back. And the nutritionists, the dietitians were frustrated, the patients were frustrated. So they came in and asked if I could make a difference with small changes. And I said, well, not on the front end when they're medically trying to reduce weight in order to make, right, for reduced risk of death. But in the long term, I've developed a 12-month follow-up program where they met monthly with us as a group. And we found that they regained 73% less weight by working through small changes, not compared to when they were restricting at 800 calories a day with the physician and the medical liquid meal replacement diet, but comparing when they were eating 4,000 calories a day. We made changes relative to those things in the long term that made a significant difference. And that study was published in Eating Behaviors. Now, so all of that science, I summarized my 20 years of research in 2 minutes on that slide, but there's another big component that oftentimes, like I've repeatedly said, that lifestyle changes and New Year's resolutions are not about willpower and not about grit, that there's so many other factors, including whether our motivations for change are internal versus external, which we can talk about, which are important factors. Social support that you have. If you do not have social support, you are significantly less likely to be successful in making any lifestyle changes. But the thing about that is that when we, in their treatment programs, we talk about social support is not a passive thing. That's something you either have or you don't. It's active, it's dynamic, and can be changed. And that's one thing that we target in treatment, is helping understand what types of support and which ones we need to be dialing up, which new things we need to be creating, which ones maybe we need to be decreasing. And then ability to handle life stress. Stress is the #1 predictor. Mental health issues of disability and inability to make behavior changes and adherence to medication. We are not talking about that in care for our patients currently. And self-efficacy, people's confidence. So it doesn't matter if you set the best goal. If your confidence is 1 out of 10 that you're going to do it, we should not be setting that goal. That is not a good recipe for success. And self-efficacy and that confidence in our ability to make the goal is one of the things that we talk about every time before they actually go off and try those goal setting. And then autonomy, giving people a sense of their own ability to do it on their own and have that efficacy and autonomy, and not just relying on other people, but that's also things of how programs can help promote better autonomy in terms of supporting someone in their behavior changes. And then psychosocial strength and stability. So this is where it leads me to about 8 years ago, that one of the world leaders in well-being and happiness, Dr. Ed Diener, he's in the US. He actually passed away a few years ago, but I continue on our work to honor him. He was identified as one of the most influential psychologists and professionals in our field. And he essentially said, I want to help people improve well-being and happiness. And he did the science of psychology behind happiness and well-being for 30 years, but he never knew how to develop it in intervention. So he had all these different things. Social relationships, by the way, are the #1 predictor of well-being and happiness. But actually, it's not a passive thing. Again, it's an active thing that you can build and create over time, but that's a skill. So what we did was partner with Dr. Diener here in Canada, and he helped set up our new center here in the Okanagan. And we developed the Enhanced program that combined my 20 years of my research in small changes with the 20 years of science and social psychology to develop the Enhanced Wellbeing program. That program has been published in several different journals, showing that now this 12-week program is effective in person, online, or even in a self-paced podcast delivered program. Access to the program that I'll be giving you today at the end of the talk. And essentially, it showed that this program didn't only improve mental health outcomes in terms of their feelings of well-being and happiness, it also improved physical health outcomes. It decreased people's sick days. It improved their physical health reportings, and it improved their physical activity and daily activities of life, which are the most important for functioning. So the Enhanced program has 12 sessions. Dr. Diener actually did the first tutorial soon prior to his passing, and he did the welcome to the program. And then I had a former PhD student, Dr. May Kanapur, who guides you in 15-minute segments through values and goals, physical well-being, mindfulness, dealing with the negative. Cognitive and negative things are an absolute core component of life, and that we use evidence-based strategies to help talking about it and dealing with it, and then dealing with the negative part 2, talking about close relationships, social interactions, gratitude and savoring happiness of others, personal strengths. And then the last one, I did the tutorial on moving forward to summarize everything and to talk about next steps. And we have those different activities that you can download if you want to see them, but the tutorials are stand on their own, and you can just listen to them in the car, on your iPad, and it's really meant to be all evidence-based, but help you as a collective way to move forward. So as a part of this work, combining my small changes with Dr. Diener's well-being literature, we added another goal. So remember, I've got small goals and we've got the QQF. The last thing I'm going to talk to you about the development of the kind goal. Any goal that you are making needs to be keeping in with your values. Again, if what you want to do is improve your health and well-being because you want to live longer and be able to play with your grandchildren, like my father who just turned 80, and with the passing of my mother this year, he has doubled down on his health and well-being because he's prioritizing, he's valuing wanting to spend time with our family. And that makes a big difference on his focus and motivation for behavior change. And it matters in keeping with your values that the goals are based on that. And that the goals are intrinsic versus extrinsic. In one of the sessions, I talk about the difference between extrinsic goals, like my kids told me I should lose 20 pounds, or my doctor said I need to get healthier, versus, you know what? I'm tired of feeling exhausted all the time when I get out of bed or at the end of the day. So I'm going to do something different because this is something I'm wanting, extrinsic versus intrinsic. And then also negotiable. The biggest thing that I've seen when people are so hard on themselves, and that I really encourage this grace and compassion in how they're going about it, is that kind goals, and that has to be negotiable and flexible. So maybe you don't achieve your goal exactly the way you wanted to, or that day or that week, but be flexible in figuring it out and knowing that things happen. schedules happen. I call it, we have lives that live in the A zone, which is everything is puppy dogs and rainbows and everything goes according to plan. And then we have the B zone that we still had some plans, but we're, trying to modify our plans. And then there's the C zone. And I can tell you firsthand, my life is the C zone. It's chaotic, it's busy, it's hectic. And so I'm always living within the C zone. So you want to be flexible, that I might have had a plan A, but I'm flexible in saying, hey, just getting up, brushing my teeth, getting my children to school without too many meltdowns, and get to my talk here at 12 o'clock today is the success versus other things I maybe had on my plate for the day. And then the last one is the D for the doable. I find repeatedly that people are so hard on themselves and they try to overachieve because they want to make that change so badly. But starting with a doable goal that's smaller, and that you come back and you say, hey, no problem, I could do that 5-minute walk to the mailbox and back. I'd rather you come back at the end of the week and say, no problem, let's build, versus I barely did it and I'll try to keep doing it again. So doable is another really critical element. Now, the only thing before I finish, just got a couple slides left, is that I want to share with everybody, in 2018 at UBCO, I opened a walk-in mental health clinic that is a free resource, barrier-free service that was started in person, but in COVID, we moved to virtual online, that's accessible to anybody in British Columbia. You don't need a referral from a physician. And you can see a doctoral student in our clinical program along with a registered psychologist for up to 5 sessions to talk about whether it's your diabetes, whether it's your physical activity, whether it's your depression, because all of those things impact your ability to be able to make behavior changes. And I will say that I have fantastic health benefits with UBC, and I see a psychologist twice a month. I'm so grateful because they help me with stress management. They help me when my mother passed away, deal with grief and loss. They help me with other things that help me move forward so that I can be as healthy as I can be. In this program, I'm so grateful to say it started as an unfunded pilot. I started it with no money, and then a private donor came forward and gave me $100,000 to keep it going with the goal of making it permanent in 2 years. And in 1 year, UBCO was so fantastic. They came forward with permanent funding, and we've now expanded that clinic to 2 days a week. There's that link on the bottom right. You can also go to that website and you can call our clinic and make an in-person or a virtual appointment. And our team would be happy to provide this and give you some of that support, in addition to the enhanced well-being program that I'll give you the link to throughout from my core website. Because my long-term advocacy goal for 4 years has been with the government that patients in our province need access to evidence-based mental and behavioral health services, just like they have access to cancer care. They need access to mental and behavioral health evidence-based services, including coaching and other components of that, to help them make lifestyle changes, to improve their health, and to live healthier and happier lives. And I can say I've been working hard with the government and making some very good headway with, and excited about some announcements to come out this spring with our government with increasing access to evidence-based services. So my plan is that this will be province-wide and accessible for coaching, as well as other resources and access to psychologists as a part of your healthcare. So with that, I want to summarize with my final slide that I was thinking about and wanted to be, how could I maybe help leave you with the following thoughts? And here's what I'd like to leave you with. Behavior change is hard. Please do not go it alone. Use evidence-based programs such as this one or other programs out there that give you what you need based on the direction that you're trying to go. Be graceful with yourself and how you go about your goal setting. You are not failing if something doesn't go well. You are figuring it out. So just keep figuring it out. You'll figure out all the things that don't work on way to figuring out what does work for you. Take it one behavior at a time. Please don't try and put everything all at once together. Make it small, make it relative, and make it in accordance with what you value. And please reach out for help and support when you need it, as I will continue to fiercely advocate. I think that's what the leaders of the different parties and government officials would say, as I fiercely continue to advocate for everybody to have access to evidence-based mental and behavioral health services as a part of their primary care services. I hope that you will take into consideration these things today as you move forward. And I hope that you found some of this information helpful. So with that, you don't have to have it all figured out to move forward. One step at a time, just take the next step. Try one small change. Try reaching out. Try the program for listening to some materials, but just take one step at a time. So with that, I say thank you so much. And I did, if you go to thecorelab.com on my website, you'll see that I have the enhanced program is at the bottom. If you click on it, you have all free access to all the different sessions. That's an evidence-based program along with the materials downloading for 4 of those sessions. So I think I'm on time. And with that, I say
Right
thank
on
you.
time.
Okay.
Alrighty. Great. Thank you so much, Dr. Lutz, for such, a valuable presentation with, the tools and giving us examples. We will open up the floor for Q&A. Does anyone have any questions for Dr. Lutz today? Feel free to unmute yourself or just type it in the chat. All right. I actually have a question. So I think someone brought it up earlier, but with the emergence of ChatGPT and like AI, do you see those tools being valuable when it comes to setting like goals and plans, resolutions related to health and well-being?
I think there's a place for give some ideas like what work for other people when they set goals. I heard someone earlier before we started talking about SMART goals and that they put it in Chat GPT and they, spewed out all these things. I I'm more, I want to make sure that people don't get misinformation and that the goal and any ideas that we're talking about, again, are linked to their life that are going to be a good thing for them. And so an AI thing it can't create goals that would be tailored to you and your needs and what's going on with your life. And that's why, I've spent the past several years, with the Diener Foundation and with the work that we're doing to try and help, understand that it is about understanding these components and what you value, what's important to you, and that's the origin of how goal setting, right, and getting proper supports. And if you live in the Burnaby, primary care area, you have access. Actually, we've hired 7 health coaches and a psychologist. They now deliver my Small Changes program. I gave it to them for free. It's access in over 60 primary care clinics with the physicians that you can actually get free coaching right now as a part of your healthcare in Burnaby. But I'm not a fan of having someone else, be it someone telling me these goals or just an AI. Like, it doesn't make it meaningful and authentic and connected to you and your life about what you need. But if you want ideas or what works for other people, I oftentimes in our group sessions, when we do group treatment, some people find ideas of other people. Oh, that's a great idea. I didn't think about that. And maybe I'll try it. But having other people tell you what might work for you is different than you hearing other ideas out there. So if you want to search the internet about what has worked for other people, like some people always tell you what works for them. But I think taking into consideration what works, thinking about your life, right, and your time. Again, I'm never going to set a 6 a.m. goal ever again in my life, even though I've tried it, right? Because that's just not, that doesn't work in my life. And so that's just why again, with that perspective taking, is that it relates to you and your life, what might work. I know that's not really an answer, but hopefully
Yeah. For sure. Understanding like the more individualized aspect and tailoring towards individuals rather
yes.
than, okay, great.
Yep.
Yeah, we have another question. So the resources you listed, are they available for people who are not in BC or like in other provinces? Can they access those?
So enhance, yes, anybody can answer. I've made those publicly available to anybody, but for the therapy component in terms of the walk-in clinic right now, that is currently only accessible to patients in BC
Okay.
because of limitations with actual like our licensures. So we're only license to treat patients in British Columbia right now. Now we are looking right now, we're working across all the provinces to look at pan licensure across Canada. So hopefully that's one of the other barriers. I'm very focused on reducing barrier to access to evidence-based treatment that's going to save time, money, and lives, and that's one of them. But currently right now for this clinic, it's only available in British Columbia.
Thank you. And we have a question from Howard. You have your hand raised?
Yes.
Yeah. You gave kind of generalities on how one sets these goals and that, and I found them quite fascinating. But I was tested myself recently for food sensitivities and stuff like that. And if I'm looking at setting, and I actually followed the diet quite well, I'm wondering how one could approach setting goals that would conform to that, but also look at the types of foods you eat and the frequency and whether they're quote unquote healthier types of foods and that kind of thing.
Yes. So with the food sensitivity, I actually have several family members that are celiac and a lot of food sensitivities and allergies. And so, yes, it definitely can work within that QQF, but like, and if you're able to adhere to kind of those changes pretty quickly, then that is great. Like you might not need the QQF, but if you're still struggling with wanting to tweak some other things, the QQF could really, really help you in that way of starting to look at some of those changes within the quality, the quantity, or the frequency. But if you have some foods that you just absolutely cannot eat, right, that's a different thing, right? That you have to take things fully out of your diet for, because of allergies or different things. Is that what you're talking about?
More sensitivities than allergies, but yeah.
Yep.
And I've had no trouble with doing it. It's a pain in the neck if you want to go out for food, though.
Yes, I have one aunt actually that has to go to the hospital if she has anything cooked in an oven that has, right, she's so severe with her celiac. So it does make eating out and different things challenging. But I, again, start to think about, is there one place that you can find that does allow for those foods? And we found like 3 or 4 places now that she can go, but it's a process. And again, hopefully just being patient with yourself and realizing like, though it does impact because you feel awful, right? Now to understand why you feel awful though can make a really big difference when you start to feel better. But I think it is understanding that you do have more limitations and working within that still, figuring out what you can do. So I hope that the QQF might still be beneficial in some ways for you as it relates to that.
You said that we'd get some link to this. I tried to open the link that was in your presentation and it doesn't, I was unable to do that.
Oh, okay. Well, I'll just pull, you mean to the core lab?
Oh,
Whichever the one that came up, I don't
Oh.
remember the exact name.
Oh, I'll send both the links then in the chat as soon as we're done. I'll send the link as you guys are still online. I'll send the link for the walk-in well-being clinic, virtual or in person, and then I'll send the link directly from my core lab research center. And so you can have both of those and I'll put them in the chat for you.
Awesome.
Okay. And I know we have 2 online questions, right? I see, does your approach work for people with anorexia needing to put on weight as a component of treatment? So I've not done a specific randomized clinical trial in patients with anorexia. What I would tell you is that that's just like for someone with like that at risk for death from the other side, the end of spectrum with weight. In terms of anorexia, we need to stabilize. That's the first thing, is making sure that you're medically stable, and whether I had one patient that we did small changes after they got medically stable, after they had to go inpatient to have feeding tube and get like actually stabilize their weight, and then small changes. I currently do that now with several patients here that I'm seeing, that once someone is medically stable, making small changes about maintaining those things and making changes across time. Yes, I have seen clinically in the work that I've done, but I've never done a traditional randomized clinical trial with patients with anorexia versus others. But the restriction the same concepts apply, but I would say the very first thing is making sure that you're with a physician, that they're getting you medically stabilized, and whether you need inpatient or care to make sure that you're medically stable. And then this could be a component of treatment. Usually with someone with anorexia, I would recommend that they're working with a psychologist as a part of their treatment. And I'm working hard to get it publicly funded.
Great. Thank you.
So,
And there was
yep.
sorry, you can
Does this
continue.
program work with obese population that are considering Ozempic type solutions? Absolutely. I would say over 1,000 of the patients that I've been working with in trials, a lot of them actually in North Carolina that I lived in Eastern North Carolina where I directed the PhD program in clinical psychology there. Patients in Eastern North Carolina were dying 10 years younger than patients just 90 miles west of them at Duke and Chapel Hill, that the geographic changes and the environment was so drastically different, and the risk of early death. We had a lot that's why I was there for so many years. And actually I came back because member family is my number one thing. I came back to Canada when my mother became ill so that I could spend more time with her in her final years of life. But those patients there, we were able to show for patients that were obese at risk for that either overweight, obese, or metabolic syndrome, but not yet with diabetes or diabetes and needing to consider Ozempic. Over half the population in one of my trials was already on insulin. And we found using small changes, they had significant reductions in not only are the distress or depression or anxiety, but significant reductions in their hemoglobin A1C. And so it's not an either or. The only thing I didn't talk about Ozempic, obviously that is the rage of now saying, well, we don't need lifestyle changes. We just need Ozempic. But I want to be clear, it's not either or, it's both, right? As soon as you go off that medication, every single trial shows that you regain the weight. So it's no different than if you go off a blood pressure medication, that your blood pressure is going to go up. And it's not just either taking the medication or looking at lifestyle behaviors as a component of, it's both. So I would encourage, if you're considering Ozempic, 100%, I 100% believe that like the metformin trials, that Ozempic, the other GLP agonists, that they have real role and potential, just like high cholesterol medications, just like hypertensive medications, to play a significant role in helping people from the biological standpoint improve health. But the lifestyle, the cognitive, the emotional, and the behavioral components are absolutely critical and impact people's ability to maintain their weight and changes across time.
Great. Thank you.
Okay, and
We
I have a
a-
patient in my other building in 1 minute. So I saw 4 patients this
Okay.
morning, came over here. Now I'm
All right.
heading back to my clinic, but
All good.
I didn't get to talk more interactively with everybody, but thank you so much for your time. I hope you found this helpful, and I will put the 2 links in for the walk-in clinic and the enhanced program before I leave.
Sounds good. Thank you so much, Lesley, Dr. Lutz, for joining us today. If you have any questions, I will post her lab's email in the chat. If you have any questions, you can direct your questions there. And yeah, thank you so much. I know you have to run, so I'll leave you to be, but
Okay.
yeah,
I hope
thank you.
everybody looks at a small goal, a kind goal, or a QQF goal in your breakout. I wish I could stay. I'm sorry, but I've been out of clinic for 4 weeks and I have some people that need some acute attention. So I hope you consider one of those 3 goals for in the breakout room. But thank you, everyone, and happy. Just Lily, send me any other questions if they come, but I'll shoot that in the chat now.
Great,
Thanks,
thank
everybody.
you.